Okay, so we're back, and now we're going to talk about the physiology of the urinary system. So here we go with, I want you to concentrate on these three things when it comes to the nephron or the kidney: filtration, reabsorption, and secretion. These three things, when I ask what does the kidney do, it does a lot more, but these are the three major things that I want you to remember. Of course, we're going to talk about the regulation of the urine volume, and then what the urine is composed of, so urine composition. And then we'll go into some acid-base things, and that will be this entire, complete this entire video. So, let me preface this by saying the physiology of the urinary system includes the chief functions of the kidneys are to process blood plasma and excrete urine, which maintains the body's fluid balance. So the fluid balance of the body is maintained by the urinary system. Nitrogenous wastes from protein metabolism, that's urea, leave the blood through the kidneys. So when protein breaks down, its waste product are nitrogenous waste, and that will be in the form of urea. Kidneys also influence the rate of secretion of the hormones ADH, which are antidiuretic hormone, aldosterone, and they synthesize vitamin D, erythropoietin, and certain prostaglandins. So I need you to know that the kidneys are involved in more than just fluid balance. They're also involved in making vitamin D, prostaglandins, and some blood products, erythropoietin, right? So the basic functional units of the kidney is the nephron. You guys remember the nephron. It's got a glomerulus, a Bowman's capsule, a proximal convoluted tubule, a loop of Henle, a distal convoluted tubule, and a collecting duct. Glomerulus, Bowman's capsule, proximal convoluted tubule, loop of Henle, distal convoluted tubule, and a collecting duct. That was the nephron. The basic functional unit of the kidney is the nephron. It has two main parts. We remember that this part is the renal corpuscle. It includes the glomerulus, this tuft of capillaries here, sitting in Bowman's capsule. So the glomerulus and Bowman's capsule makes a renal corpuscle. You'll remember that. And then the other part connected to this renal corpuscle is just the tubule. And that is this part with the distal, with the convoluted tubules here and the loop of Henle and the collecting duct. Convoluted just means that it's wavy like this, you know, like an egg carton. Eggs can fit in here. That's a convolution, right? So two main parts. You got the renal corpuscle, which includes the glomerulus sitting in Bowman's capsule, and then the tubes. That's all it is to the nephron, right? Renal corpuscle and renal tubule, and it forms urine by three processes. Let's go down to the first one. Filtration. Filtration, or the movement of water and protein-free solutes from the plasma into the glomerulus, across the glomerular capsular membrane, and into the capsular space of Bowman's capsule. So filtration, let me go over that in other words, is the first step in blood processing. It is a physical process that occurs in the kidney's 2.5 million renal corpuscles. 2.5 million renal corpuscles, right? So it's 1.25 in each kidney, 1.25 million in each kidney, renal corpuscles. As blood flows through the glomerular capillaries, so blood is going to flow through these glomerular capillaries, water and small solutes filter out of the blood into Bowman's capsule. Blood cells and plasma proteins do not move out of the blood. So here, for the most part, things that go and stay in the system, our system, will be glucose, amino acids, proteins, etc. That doesn't stay in the system. That comes out. If you have proteins or glucose in your blood, that is going to be indicative of a problem. Usually proteins can be in the blood only if some proteins can be in the blood if you are pregnant. But other than that, albuminuria, which that would be called protein in the blood by albumin, you would not want to see that. Glucose in the, not in the blood, in the urine, I meant to say in the urine. You want proteins in the blood. But in the urine, you don't really want to see that. And glucose in the urine could be indicative of a diabetes, unless you're just eating a 10-pound chocolate cake all in one sitting. You will have reached your T max and glucose will spill over to the urine. And that's so not necessarily going to be diabetes in that case. You eat too much sugar at one sitting. So blood cells, plasma proteins do not move out of the blood. About 180 liters of filtrate or water is formed each day, but only a small amount is excreted into the urine. A lot of water is filtered each day, but only a small amount is excreted into the urine. So that's filtration. I need you to understand that this is the mechanism of filtration where the glomerular capillaries are. Reabsorption, this is the second step in urine formation, and it takes place by means of a passive and active transport mechanism from all parts of the renal tubule. Now your text is going to show you what things are coming out or into the tube, out of the tube, etc. We're going to talk about that in a minute, but very specific parts of the renal tubule will be discussed in the text, and I want you to look at those pictures for that. From all parts of the renal tubule, major portion of reabsorption occurs in the proximal tubules. If you want to know about something, this portion here for reabsorption is the workhorse. This is what we call this. This is the workhorse of the nephron. Workhorse of the nephron is the proximal convoluted tubule. You can see things that come out of this tubule, and that's reabsorption. We're going to talk about that, reabsorption and secretion in a minute. Let's go to the next one, secretion. This is the third step, and it moves substances out of the blood and into the tubular fluid. So secretion will move things out of the blood and into the tubular fluid. Anything that's going into the tubular fluid is going to end up here in the toilet. If you stay in this tube, you're going into the toilet, okay? So reabsorption is secretion is the third step. It moves substances out of the blood and into tubular fluid. The descending limb of the loop of Henle secretes urea via diffusion. The distal and collecting tubules secrete potassium, hydrogen, and ammonium ions. Aldosterone, that's a hormone, targets the distal and collecting tubule here and here and causes increased activity of the sodium-potassium pumps. Secretion of hydrogen ions increases with increased blood hydrogen ion concentration. So the more hydrogen ions, which means your blood is becoming more acidic, that concentration, you will end up secreting those hydrogen ions with increased blood concentration of hydrogen ions. So here, I want to go over what direction things are going. Let me start this over a little bit. I want to make sure you understand secretion and reabsorption, the direction of those things. So I'm just going to draw the glomerulus, Bowman's capsule, this, that. When something is coming out of a tubule, just say this way, and a lot of it comes out here. This direction, these are coming out. This is reabsorption. It's coming out into the body to be reabsorbed. And like I said, the glucose, the amino acids, the proteins, etc. And sometimes a lot of water is reabsorbed too. So I'll just put water over here. That's reabsorption. So reabsorption. On the other hand, we have something going into the tube, into the tube, into the tube. That's called secretion. Secretion. Going into the tube. When you secrete, you excrete. So it goes into the toilet. It stays in the tube, secretion. How is all this occurring? Well, you have to remember, from your efferent arteriole, you have a peritubular capillaries that are going all around. Secrete, let's see, you want to reabsorb something that's going in this tube, then put it into the peritubular capillary, it will come back to your body to be reabsorbed. You want to secrete something and you want to put it into the tube, then you can take it out of the peritubular capillary, put it into the tube, and then you're going to secrete. So the way this goes is, if it's coming out of the tube, that's reabsorption. If it's going into the tube, that's secretion to be excreted. So secretion and excretion go together. So if it stays in the tube, you know it's going to be on its way to being excreted, because it was secreted means it's going to be excreted. Reabsorb means it's coming out of the tube, coming into our bodies, and it will go into the peritubular capillary, which came from the efferent arteriole. And we talked about that a little bit before. Let's go over the regulation of urine volume. And I didn't mention this before, but that's the distal, this is the proximal convoluted tubule. This is the descending limb of the loop of Henle. Then you have the loop of Henle here, and then that's the ascending limb. I wanted you to know that the urine is indeed moving this way. And I should have made that point before so that you will know how does the urine get into the toilet. It's because it's coming from here, going down the descending limb of the loop of Henle, around the loop of Henle to the ascending limb, through the distal convoluted tubule down the collecting duct, if you can follow that. All right? Last, let's look at this regulation of urine volume. So ADH, and we said that was antidiuretic hormone, it will influence water reabsorption. And remember, reabsorption is when the fluid is coming back into the body. So ADH, antidiuretic hormone, that means that you will antidiuretic hormone, ADH. Anti meaning against, diuretic means to urinate, so it's against diuresing, against peeing, against micturition, against voiding hormone. This hormone prevents you from urinating, right? Okay, antidiuretic hormone. It influences water reabsorption. As water is reabsorbed, the total volume of urine is reduced by the amount of water removed by the tubules. So if you have a high degree of antidiuretic hormone being released, usually seen in a time when you are dehydrated, you are not going to urinate because you don't have enough, in this case, it would mean that you don't have enough fluids to make the volume of urine to urinate. Now I'll go through this in a minute. So you're going to reabsorb water as much as possible and hold on to it. So antidiuretic hormone influences water reabsorption. As water is reabsorbed, the total volume of urine is reduced. So you're going to reduce urine. You're going to not urinate. Antidiuresis, you're not going to urinate. Aldosterone, secreted by the adrenal cortex, increases the distal tubule absorption of sodium concentration of the blood. Aldosterone, whenever you think of aldosterone, I want you to think of sodium. And when you think of sodium, think of aldosterone uses sodium to hold on to water, okay? And it promotes the reabsorption of water to keep water in the body. On the other hand, atrial natriuretic hormone, ANH, atrial natriuretic hormone is going to be quite the opposite, okay? Atrial natriuretic hormone is secreted by specialized atrial muscle fibers. This is atrial, this is in the heart, right? Promotes the loss of sodium through the urine, which opposes aldosterone, causing the kidneys to reabsorb less water, thereby producing more urine. Here, you're not going to pee. This is going to be less urine, because you're going to hold on to the water. Here, atrial natriuretic hormone wants you to urinate, so you'll have more urine. You will not reabsorb as much water. Here, you're going to use the hormone aldosterone, which is going to make you hold on to sodium. Here, you're going to get rid of sodium, and that's going to allow you to get rid of more fluid, more volume, which means you're going to urinate more. I want to show what this system looks like in a picture in just a minute, but let me introduce these. These are quite opposite. Antidiuretic hormone is going to prevent you from urinating, and atrial natriuretic hormone is going to encourage you to urinate, to get rid of volume. This is going to try to keep you from losing volume. This one's going to try to get you to get rid of volume. We're going to come back to those points in a minute, but I need you to understand the concept. Let's look at the urine composition. Urine composition, in other words, what is urine made up of? Mainly water. Like 95% water is what makes up urine, and several other substances dissolved in it. For example, excuse me, nitrogenous waste. We talked about protein breakdown, which makes nitrogen. So these nitrogenous wastes are in urine as a result of protein metabolism. Urea, uric acid, ammonia, creatinine. And remember, when we check your kidney function, we look at a BUN and creatinine. Those things will tell us how good a shape of the shape of your kidneys. A BUN is the urea, and the creatinine, or the crit, is the BUN and creatinine. Electrolytes are also in urine, mainly the following ions. You have sodium, potassium, ammonium, chloride, and bicarb, phosphate, and sulfate. These amounts and kinds of minerals vary with the diet and other factors. So depending on how your diet is, the composition of your urine will be affected by that. Toxins. Toxins leave the body through urine when you have a disease. You usually are not walking around toxic, like so many people keep telling you that they're on a detox diet or they're detoxing. That irritates the crap out of me, because if you have functioning lungs and kidneys, your body is already detoxed you. You're not toxic. Now, if you have an illness or disease, possibly you do have toxins that are building up, and your urine should be there to help get rid of, flush the toxins out, but only during disease, right? Usually, under normal circumstances, please stop saying you're detoxing. That is irritating, and it's not true. Toxins during disease, like bacterial poisons, leave the body in the urine. So that may be in the urine composition. Pigments, especially urochromes. Urochromes means urine color, and it makes the color of the urine should be like a pale yellow, right? If your urine is very amber, very yellow, then you need to drink more water. Simple. You don't need to say you're dehydrated. Dehydrated is a medical term. Stop saying that. You're thirsty. Just because you're thirsty does not mean you're dehydrated. Like just because you're hungry doesn't mean you're starving. You say that oftentimes in this country, oh, I'm starving. You know, there are people that really are starving, and they will pop you in the mouth if they heard you say that. You're hungry, you're not starving. You're thirsty, you're not dehydrated. So stop saying that too. And I hear people say that all the time. Well, if you're thirsty, that means you're dehydrated. That's not true. Dehydration is a medical term that has nothing to do with you being thirsty, okay? Necessarily. All right? So just stop all this mumbo jumbo, just using words. Just think about what you're saying. Hormones are also in the urine composition. Hormones. High hormone levels may spill into the filtrate. Now I say hormones because I want you to remember HGC, human gonadotropin, chorionic gonadotropin hormone, HCG. That is the hormone that when you urinate on the stick to see if you're pregnant, that hormone is in the urine, and it will come out as a plus or minus if you're pregnant or not. There are some abnormal constituents in the urine. Now, all the things we mentioned before were normal to have in the urine under certain circumstances. But abnormal constituents, things that should not be in the urine, are blood. You should not be bleeding. If you see any blood in the urine, and I'm not talking about women that are on menses, because that's not in the urine, it's just coming out through gravity from the vagina mixing with the urine. But if you have blood in the urine other than being on menses, your period, then something's not quite right. You should not be bleeding from the kidneys or anywhere in that tract. Glucose should not be in the urine. Albumin should not be in the urine under most circumstances, but it can normally be in there if you are pregnant. It can be. You can have some albuminuria. Casts should not be in the urine. That is an indication of bacteria. And calculi, that's like a hard crystals that may show that you're getting kidney stones, and that will be from not drinking sufficient water. So those things are abnormal. Blood, glucose, albumin, casts, or calculi should not be in the urine. I want to go over this renin. So these are things that the physiology of the urinary system. I want to introduce these two concepts, and I'm going to go over it in more detail so that you can see how this goes together. Those two hormones, I'll just erase them. I think you have them understood now. But if you don't, you will understand them in a minute. All right? So let's look at this system. The renin, angiotensin, aldosterone, aldosterone system, okay? And I'm just gonna erase that so we don't have so many systems up here. All right. Now, the renin, angiotensin, aldosterone system is a system that kicks in when your blood pressure is seen as low. In other words, your volume is detected as low by your kidneys. So this is going to be a decreased volume. And when we have a decreased volume, that usually registers as a decrease in blood pressure, right? What are some ways we can have a decrease in blood pressure? Just name some ways we can have a decrease in blood pressure. Good. Dehydration is one, where maybe we were out in the garden working for hours and hours, right? Didn't drink, the sun is beaming down on us, and we feel a little dry, but we just keep working. We haven't urinated in hours, but we're still out in the sun, and we're just having a good time working in the garden. Well, you could get a little dehydrated at that point, right? All day being out in the sun, you could get a little dehydrated. Hemorrhage would be another way that we could lose volume and our blood pressure would go decrease. Having emesis, vomiting, especially a lot of vomit, a lot of emesis could cause us to have less volume and a lower blood pressure. Diarrhea can cause this. Profuse sweating can cause us to lose volume and have a lower blood pressure. I've heard that some boxers, just say like Mike Tyson, or just a basketball player, say Michael Jordan, they can lose like 15 pounds in sweat. So that is a lot of fluids leaving the body. So they have to stay hydrated. So they could cause a decrease in blood pressure. So when you lose volume, you can decrease your blood pressure. And let's see with this system what happens when that occurs. So let's draw the kidney. That is the kidney. And during times of low volume, low blood pressure, like we just mentioned, this system will kick in. And what will be released will be renin from the kidney. It will be released, and here's a big molecule here, angiotensinogen, which is inactive. Big clunky molecule is inactive. Renin will then cleave it. Renin will cleave that angiotensinogen and make it angiotensin. Now this is angiotensin 1. It's not a big old clunky inactive molecule. It is now considered to be active. Angiotensin 1 will then go and activate the lungs, an enzyme in the lungs. So let me draw this, lungs, or lung, I just put lung. There's an enzyme in there called ACE. And now it's angiotensin converting enzyme. You can see the ACE here. And that will now make angiotensin 1 even more active. And we'll call it angiotensin 2. Right? Then, I'm running out of space. Here, we got the kidney. But sitting on top of the kidney is a little gland here called the adrenal gland. Adrenal gland. The adrenal gland it has hormones in it. One like where you get your adrenaline, epinephrine, norepinephrine. But anyway, here we also have aldosterone. Aldosterone will come out. Aldosterone. And remember, We said when we see aldosterone, we're going to associate this with sodium, right? We're going to increase our sodium, which will increase our water retention, which will increase our volume. In exchange for holding on to the sodium, we got to get rid of something. So that positive ion will get rid of, we'll get rid of potassium. That will decrease. So that is, so that makes our blood pressure go back up. So look at all these things that are occurring here. The kidney is involved. Once you see a blood pressure that's really low, or depletion in volume, which will affect blood pressure, as you know, the kidney will release renin. Renin will then cleave this inactive molecule angiotensinogen into angiotensin 1, an active molecule, which will then spur the lung to start with this enzyme, spur out this enzyme, angiotensin converting enzyme, to make angiotensin 2, which is an even more active molecule, to activate the adrenal glands, aldosterone, and increase the amount of sodium, holding on to sodium in the body, increasing water, which will then increase volume, and then get your blood pressure back up. Now, most of us in this country don't have a problem with our blood pressure being too low. Most of us have a problem with it being too high. But the point I'm making here is that's why one of the first things a physician tells you is to what? Decrease your sodium. Because if you decrease your sodium, you can decrease your blood pressure. But here it's high or increased because you want the blood pressure to be up because the system detected a low blood pressure. But the first thing you want to do if you want to get your blood pressure right is to significantly decrease your sodium. In this case, the blood pressure was low because of dehydration, maybe too much vomiting, too much diarrhea, whatever, maybe the person had cholera, I don't know, but the blood pressure was low. Maybe he's hemorrhaging, got stabbed or shot, blood pressure was low. So this system kicked in to get his volume back up and to get his blood pressure up. When you have sodium that is going to retain, please note that you have to get rid of another ion. That will be potassium, will go lower. Okay? Please remember that exchange between the sodium and the potassium. There's another point I want to make here is that, this is going to be opposite. You know this ACE here? They have ACE inhibitors. When this is for a person that has high blood pressure, that will stop this lung from releasing ACE, inhibit ACE inhibitor, so you do not go on to get a higher blood pressure. So we can use this enzyme that's in the lung to create medications that will inhibit the release of this enzyme from the lung so that you can then get a lower blood pressure. If you have hypertension, we use an ACE inhibitor, and that will stop that process and you don't go on to get even higher blood pressure, right? So I want you to remember that ADH, which we talked about before, antidiuretic hormone, comes from the posterior pituitary gland. And this is in the brain, right? Okay? And it is there to decrease urination. I mean, this is one of the most vasopressive, constrictive type of hormones that we have in the body. And once it's activated, you won't even be able to make a tear. I mean, no water is going to leave your body. You will not urinate. You won't even have saliva in your mouth when this thing is released. Because it wants to get your blood pressure back up. It's going to hold on to all the water so you will not even urinate. On the other hand, ANH, which we saw from the atrial natriuretic hormone, which we talked about a minute ago, comes from the heart, these receptors in the heart. So the atria, remember that? So maybe you got a blood transfusion, for example, and maybe somebody forgot to log that you got the blood transfusion. Now you got somebody comes and gives you another one. So now your atria from your heart are just bulging out here and here. They're like, whoa, whoa, they're bulging out. So much blood is coming in from the superior vena cava, inferior vena cava, and the pulmonary veins. So much blood is coming into the atria, and these receptors are like, oh my God, this is so much blood. Atrial natriuretic hormone will say, hey, this is too much fluid. This person must urinate. So this is to increase urination. So those are the two hormones I wanted to mention. I do want you to also know that the way that we actually can draw a nephron so that you can understand the mechanism of the kidney. I'm going to just put it here so that you can see how the kidney even knows to release renin because of this low blood pressure. And this is something I mentioned before, that the afferent arteriole has some special cells in it. You have juxtaglomerular cells around and the macula densa around the afferent arteriole. Those things will communicate with the distal convoluted tubule in such a gentle way to let it know, hey, I don't have enough fluid coming into the kidney, what's going on? And that will start this cascade here. So in order to do that though, the nephron has to be switched, it has to be flipped, and I need to show you that. I taught it one way, but really it's flipped. So remember, we learn the nephron this way, and I'm just going to show it this way. Right? And you have the afferent arteriole here and the distal convoluted tubule over here. So remember, this is the proximal convoluted tubule, this is the distal convoluted tubule. Right? And we got the afferent arteriole. So I'm going to just cut this right down the middle, and then I'm going to take this distal convoluted tube, I'm going to take this collecting duct and fold it over. And I'm going to show you how this will look. Because this is the way it really is, but it's just easier to teach it that way first. So let's just look at this. This is the way it really is. Can you see how I just took this and went like that? I just folded it over. This is still the loop of Henle here. Here's the loop of Henle. This is now the distal convoluted tubule, and this is the proximal convoluted tubule. Now what I want you to know is that the afferent arteriole, I'll just say this is the afferent arteriole, and the distal convoluted tubule are in communication with each other. It's just like a gentle kiss that they share. But it's enough to let the distal convoluted tubule, whether or not it should let urine come out into the toilet, as will be the case here, or if it should hold on to urine and not let a drop come out, as would be the case here. And that's how this system works. The kidney with this nephron will communicate. If enough fluid is coming through, well, then the afferent arteriole is like, hey, it's enough going on, enough fluid, it's cool, you can go on and urinate, you got enough. But if the kidney detects that, hey, it's not enough volume, not enough fluid, the blood pressure's dropping, we're stopping this system. That gentle kiss between these cells, the macula densa, the juxtaglomerular cells, and the distal convoluted tubule, with this afferent arteriole will communicate that, and then you will have the brain going into this antidiuretic hormone system and not allowing urination. So the next thing we're going to talk about, and I hope that explains that well enough for you. It's in your text, of course, but I think it's kind of good to get just a general picture of it before you start reading, and then as you read it, you can understand it even more. So if you need to go to some other videos, that's fine with me. my main point is that I need you to understand the material. And for me, that's the best way that I can explain it. The other thing is that we're going to go into next will be acid-base balance. All right, let's look at the acid-base balance. Acid-base balance. So pH is a numerical symbol from 0 to 14. All over the world, scientists have decided, okay, we're going to use this pH thing to look and represent acid-base compounds or solutions. And it's used to represent the negative logarithm of a number of hydrogen ions that's present in 1 liter of a solution. It indicates the degree of acidity or alkalinity. Alkalinity is the same thing as basicity, or being a base of a solution. So pH is a numerical symbol from 0 to 14 used to represent the negative log of the number of hydrogen ions. That's important to remember. We're looking at hydrogen ions that's present in 1 liter of a solution. It indicates the degree of acidity or alkalinity of a solution. Acid-base refers to the regulation of hydrogen ion concentration. And when you want to say hydrogen ion concentration in terms, it could go like this, with this brackets meaning concentration. Of course, that's the hydrogen ion inside. That's in the bodily fluids. Now, acid-base turns out to be a perfect way of looking at things when we look at water, for example. Water, you know, is H2O. You got your H, and you got your OH. I'll just put it like that. This will represent an acid, and this will represent a base. So water is the perfect acid-base balance. Acid is hydrogen ions, base are hydroxyl groups. So you can remember it that way. Right? Okay. So water is the perfect acid-base balance. So this is acid, that's base. Many bases release hydroxide, which react with the hydrogen, of course, to form water. Right? All right. I want you to know that although the acid-base refers to the regulation of a hydrogen ion in the body, even slight derivations from normal pH in the body's cells and fluids can result in potentially fatal changes in the metabolic activity. You have to maintain an acid-base balance that's necessary for our survival. Okay? Let's look at this pH range first of all, so I can explain how this goes. So it said the 0 to 14 is what everybody all over the world has decided is going to be the range for pH. 0 to 14. Let you know that 7 is considered neutral. Everything less than 7, the pH, this is the pH scale, okay? Everything less than 7 is acidic. So 0 to about 6 is acidic. Everything less than, greater than 7 is basic or alkaline. All right? So 8, 9, 10, 11, 12, 13, 14, that would be considered alkaline. You can see in your text things that we measure. It could be tomato juice, tea, coffee, Clorox bleach. I say that as a joke. Lysol, only because those things have been quite prominent. It could be orange juice, tomato juice, anything like that, oven cleaner, etc. We measure everything like that based off of this pH scale. Now, one thing, before I learned all this stuff, I actually thought that the acidic part was like stuff that really was going to cause a problem. And then when I learned later, it's things like, I don't know, just say oven cleaner, that's really basic, and it's actually quite corrosive. So just because something is basic, this is my point, just because something is alkaline doesn't mean it cannot be harmful. It can still be quite harmful. This is why when a child swallows something, you do not necessarily want that child to throw up. You do not necessarily want to cause that child to have emesis. Why? Because if it burns going down the esophagus, it can burn coming back up the esophagus. And just because you think it was a base doesn't mean it cannot cause corrosion and burning. So keep those things in mind. There's some of the weirdest things that really have a basic or alkaline pH, right? So let's look at, the point I wanted to make here is that as the hydrogen ion, remember that's what we're looking at when we talk about pH. As the hydrogen ion increases, the pH goes down and the solution becomes more acidic. A decrease in the hydrogen ion concentration makes the solution more alkaline and the pH goes up. So I'm just going to ask you, I have a beaker, let me draw a beaker here, and another beaker here. Now fill it with solution. This one is going to have quite a few hydrogen ions in it, like a lot of hydrogen ions, hydrogen ions. I'm just trying to fill this thing up with hydrogen ions, that beaker. This one has fewer hydrogen ions. Would you agree with that? This beaker has a lot more hydrogen ions than this beaker. Okay, so I just said what? When hydrogen ion concentration increases, the solution becomes more acidic. Does this have an increase in hydrogen ion concentration, or does this one? Would this one be more acidic, or this one? If the solution has a higher concentration of hydrogen ions, then it is more acidic. So this is acidic. That means it's going to have a low pH. You see how low these numbers are? That's a low pH, and that is going to be acidic. It has a higher hydrogen ion concentration. On the other hand, this beaker has fewer hydrogen ions in it, a decrease in hydrogen ion concentration. The pH is going to be higher. Would you agree that the pH is higher? And this is basic or alkaline, whichever way you want to say it. Please remember that basic concept. Okay, so just remember that. That could be alkaline and here. Now the point is that our blood is running about in here, and this is going to lead us to the next thing I'm going to talk about. We're about in here, 7.35 to about 7.45. That's human blood pH. 7.35 to 7.45. Anything lower than 7.35 is going to be considered acidic. Anything higher than 7.45, that's going to be considered basic or alkaline. Okay? And a lot of times with asthma patients or people that have the poster child COPD, emphysema, we really have to watch their blood levels and make sure that they don't get into trouble with the pH of their blood. All right? You don't want to cause acidosis You don't want to cause basicity or alkalinity either. And we're going to talk about those things in the, I'm just trying to see here, in the next chart. So let us take a look at that. All right, so let's look at the acid-base physiology chart the way I see it. Now I'll try to explain acid-base in the best way I can. So we have a metabolic acidosis. First of all, before I get into that, let me let you know that there are three major mechanisms that regulate the hydrogen ion concentration. We have buffering systems that can do that. You got chemical buffers with bicarb, phosphate, and some proteins. You can have physiological buffers with respiration and kidney, which those are two things that we're going to use. Will be physiological buffering systems with the lungs and the kidney. Now, before I go on, let me explain these columns here. pH we just went over. So you know if you got a low pH, you're acidic. If you have a high pH, you're alkaline, okay? PCO2. Whenever you see PCO2, I want you to think respiratory. It should go ding, ding, ding. So we'll be in the lungs for that. When you see bicarb, HCO3, when you see bicarb, I want you to think kidneys. This is metabolic. So metabolic is really going to mean anything but the lung. Everything but the lung. That would be metabolic. And really that's kidneys. Because all we're going to use, metabolic. All we're going to use is, so I'm going to put kidneys here, are going to be the lungs and the kidneys to keep us straight. If the lungs are kind of jacked up, then the kidneys will take over to compensate. If the kidneys are jacked up, then the lungs will take over to compensate. Whatever the cause of these four issues are, we'll write that down. And then the compensatory response. Like I said, if the lungs are not performing optimally, then the kidneys will say, hey, I gotta take over and get this body into acid-base balance, because that's what it's always about, balance. So we're going to use two things. We're going to use the kidneys and we're going to use the lungs to keep us straight. So everything, if it's not PCO2, that means it's metabolic. That means it's everything but the lung. But in this case, we'll just say it's the kidneys, but really it's metabolic. It's everything but the lungs. So let's look at metabolic acidosis. Right away, because I said metabolic, you know that it has something to do with the kidneys, okay? Now let's find out first. Acidosis, since this is the first column. Since this person has metabolic acidosis, now, let me first tell you how we determine this. Remember I told you that the blood pH has to stay between 7.35 and 7.45. That's our blood pH. Has to be between that to keep us stable. If it goes below 7.35, like 7.33, 7.32, 7.30, that person is acidotic, right? So the pH is going to be high or low if a person has acidosis. And the way we find this out is we stick a needle right here in the artery, put it on ice in the test tube after we withdraw that blood, and we send it straight down to the lab. It comes back, the person is metabolic acidotic. That means that the pH is low. It's acidosis, you know, if you got a low pH, if you got acidosis. Now I'm going to look at lungs or bicarb. That says metabolic, so I know I'm going to look at the bicarb column because it doesn't have anything to do with respiratory. It has nothing to do with lungs. So bicarb is a buffering agent, meaning it likes to neutralize acid. So think about this. If the person is acidic, would they have a lot of bicarb to neutralize the acid, or would they have a little bicarb to not neutralize the acid? This is the thinking that you have to have. So the blood is already sent. We're looking at the blood. We're interpreting the blood now. We're in the lab. We're interpreting the blood. This person should have a little bit of bicarb because they are acidotic. So I'm going to say they have a little bit of bicarb. How do I know to go to the bicarb section? Because it's metabolic. And we said that the bicarb section will be kidneys or metabolic, because we're only going to use lungs or kidneys to get us back straight, right? In metabolic order, I should say, acid-base order. Now, the causes of a metabolic acidosis can be, you have the DKA, diabetic ketoacidosis. Let's see if I can fit it on here. This is when a person is not really taking care of their insulin the way they should. DKA and diarrhea are two ways that a person can become metabolically acidotic. What will compensate for that? Now, you know that that's metabolic, so that will involve the kidneys. We're only using two organs to keep us in acid-base balance, the lungs and the kidneys. Something must be going on with the kidneys or the metabolic system. So what will compensate? The lungs have to compensate. The lungs have to say, and the lungs can only do two things. They can either hyperventilate or hypoventilate to help get this in balance. So here, the lungs, that you're acidotic, the lungs say, hey, I better speed up your breathing. You're going to hyperventilate and get rid of some CO2. And that will make your body less acidotic, because you're going to get rid of the waste, CO2. Okay? So the lungs will hyperventilate. Let's look at respiratory acidosis. So we see as acidosis, is this pH going to be high or low? Acidotic, let's remember. It's going to be low because it says acidosis. Respiratory, will we go to the lungs or will we go to the kidneys, the metabolic column? It's respiratory. Good. Choose the lungs. Now, PCO2, partial pressure carbon dioxide, you know that carbon dioxide is our waste, right? You don't really want to hold that or retain that, because that will make our blood acidotic. Oh, I just gave the answer. So, would we have a lot of PCO2 in our blood if you're acidotic, or little? Well, I just said, if you hold on to CO2 and not breathe it out, then you're going to be acidotic. So we would have a lot of CO2 to become acidotic. What could that be the cause of? You can have COPD, chronic obstructive pulmonary disease. What's the poster child for that? Yes, emphysema. You could have an airway obstruction. You have a big old piece of apple stuck right in the throat. Oh, I can't get this CO2 out. Well, now your body is absorbing all the CO2 because you can't breathe, can't get that waste out. So now your blood is going to absorb it, and you're going to start looking kind of blue, kind of ashen, and purple lips, etc. That's not going to be good. So you can have airway obstruction. You don't always have to have a disease. Sometimes you could just be choking. You know. What is going to compensate for this respiratory acidosis? Well, the lungs look like they're a little compromised. So what is going to take over? The kidneys. The kidneys can do two things. They can hold on to bicarb and use that as a buffer to neutralize acid, or they can secrete or pee out the bicarb and then make the body more acidic. So let's see what it does. It's already acidic. So I think that the kidneys will say, hey, we need to reabsorb bicarb, put bicarb back in the body so that we can neutralize this acid. So the kidneys will take over. We have a renal bicarb reabsorption. going back to the body to neutralize this acid, because that's what bicarb does. It neutralizes acid. You're taking like, I know back in the day, my grandmother would have heartburn. She's like, oh man, I just need to belch or settle this acid that's in my chest. So she would really, literally take that Arm & Hammer baking soda, which is bicarb, put it in a glass of water, a little bit, swirl up, drink it, belch, and it would neutralize the acid. So I need you to remember that bicarb neutralizes acid, okay? And if you reabsorb it, take it back into the body, it can neutralize this acid that is going on with the respiratory. Let's look at respiratory alkalosis. So when a person is alkalotic, the pH should be increased, greater than 7.45. It's respiratory, so we know we look in the lungs. So are you holding on to PCO2 with respiratory alkalosis? Or are you releasing it, breathing it out? Or are you holding it in, something keeping the CO2 in? If you're alkalotic, you know that you're getting rid of this CO2, because when you hold on to CO2, you're acidic. So this is going to be low. Okay? What can cause that? Well, high altitudes can cause this. High altitudes can cause a respiratory alkalosis, and also hyperventilating could cause an alkalosis, a respiratory alkalosis. You could breathe out way too much CO2. Hyperventilation, right? I tell you the story about this kid that mom dropped her off to school. She's in high school. And hey mom, bye, thanks, okay, drop her off at school. She and her girlfriend skip school, go to the mall. They're in the food court eating. Yeah, we skipped school, we're bad. The mother tore her nylons. It's a time when women wore stockings and work. She said, oh, I'm gonna run over to the mall and get a new pair of nylons, stockings. And she, it's lunchtime, so she goes over to the food court to grab a bite to eat. Who does she spot but her daughter with her girlfriend sitting there going, we skipped school. Mother walks over to her and says, what are you doing? The girl just looks up and without any hesitation starts to hyperventilate. She was scared that much. She's breathing out all this CO2. All this CO2 is leaving. So her body's becoming more alkalotic, more basic, right? Because she's getting rid of the CO2. So mom was like, stop playing around. She's not playing around. She's deathly afraid now. So you take her to Children's and, we dim the lights, give her a bag to breathe into. She starts to breathe back in some of the CO2 to get her balance, acid-base balance back. And then the mom says, I'm going to kick your butt, the doctor. So no, don't do that. I think she suffered enough. So hyperventilation can cause a respiratory alkalosis. Since the lungs were involved with this, what will compensate, of course, would be the kidneys. Do the kidneys need to hold on to any more bicarb? This person is already alkalotic. Do they need any more bicarb to neutralize any acid? No, because there is no acid. So the kidneys should not reabsorb bicarb. The kidneys need to secrete, to excrete and get rid of bicarb, because you don't want the person to be any more alkalotic, correct? So that is what the kidneys will do. The kidneys will take bicarb and pee it out. And that is going to be secretion. Okay? Metabolic alkalosis, you know that the pH is going to be high. Metabolic, well, that does not involve lungs, that involves bicarb. Metabolic alkalosis, this person is alkaline. We know that bicarb neutralizes acid, makes a person alkalosis. And so that person should have a lot of bicarb in the blood. And what can cause this? This can be caused by, let me move this down a bit so that we can not get confused. Vomiting. So when you're throwing up, you're throwing up the acids from the stomach, right? We learned about that last time when we did digestion, the hydrochloric acid. You're throwing it up. So now you threw up all the acid. How does the body left? Yes, the body is left being alkalitic. It doesn't have the acid anymore. So the body is left alkalitic. And you can tell when people do this kind of serial emesis. So a lot of models do that. They'll put their fingers down and throw up. You'll see like marks on the knuckles where the teeth hit, and a lot of times they'll have to get their teeth recapped or fixed because of the acid that came up through the vomiting has eroded the enamel on the teeth. So vomiting will cause this. And since that is metabolic, what's going to compensate will be the lungs. You're already alkalitic, so now you need to hold on to a little CO2. You want to breathe slower, so you want to hypoventilate, right? I hope that this makes sense to you. Like if you need to rewind this a couple of times to get this idea, this concept, because that's really all it is a concept.